So we are now going to cover renal physiology. So this is a table that can be a good way to start the topic and also be a good way to finish the topic because it will allow us to review. So one aspect that the kidney is involved with has to do with the regulation of water and all the components that have a concentration in the plasma. So, such as, for example, the ions and other substances. It will also help with the pH that occurs in collaboration with the lungs, and all the processes that allow the regulation will allow also removal of waste products, and not only they come from the body, but it will help metabolize and remove, for example, drugs and other aspects, other substances that come from the outside. We spoke a little bit about the gluconeogenesis earlier in the semester, and we said that the kidney helps with that. Then the kidney has also roles in production of substances that have effects also in other parts of the body. So we talked about erythropoietin, we will talk about renin, and we'll also discuss the role of the kidney in activation of the vitamin D. So the first component that we are going to cover is a basic review of anatomy. But this anatomy, now that we are in a physiology course, you need to really pay close attention to different aspects of the anatomy so that the physiology becomes much easier. So let's look at the structure of the urinary system. And here you could spend some minutes even looking at this picture and seeing if you can recognize all these structures. Once you recognize the structures, you could then think about a main function, a simplified version of a function. So on the left, you see that the kidneys produce urine, and the urine is then drained into the urinary bladder through the ureter, and then will exit the body through the urethra. But you also see, for example, in that picture, you also see the relationship between the renal artery and the renal veins. So the kidney has a renal artery, and each kidney has a renal artery and a renal vein. That up to here, every organ has an artery and a vein. So, but we'll see how the arteries are going to make a system that will favor filtration. So let's look at the structure of a kidney. So when you look at a kidney cut like this, you see that the kidney, like many organs, has a cortex and has a medulla. In the medulla, you can see some pyramidal structures, which are called the renal pyramids. The renal pyramids terminate in a region called the renal pelvis. So all the urine drains into this renal pelvis, and then from the renal pelvis, the urine will be drained into the ureter and then urinary bladder. You see there an image of a nephron. A nephron is the basic unit of a kidney, is a structural and functional unit, meaning that the product of the kidney, which is essentially urine, results from the activity of each of these nephrons. So each of these nephrons is producing some amount of urine. And the sum of all the nephrons' urine is the urine that's going to be drained into the ureter. So from a numeric point of view, from a number point of view, a kidney can be evaluated by the number of nephrons that are active. If we lose nephrons, we are going to lose kidney function. Likewise, for example, if we lose alveoli, we lose lung function. This is a better view of the kidney. For us, this is not an anatomy class, but it's important also to mind that we have a fibrous capsule. The fibrous capsule is not so much important for physiology, but it's more important pathophysiology, because you know that structures that have a capsule have a limit space. And that space can limit, for example, neoplasias that are growing in the kidney, but it can also be a limit for any sort of other expansion, such as, for example, in the case of inflammation. And that may cause pain. If there's an inflammatory process of the kidney, it may cause pain. So as of here, we see essentially everything that we've talked before. And now let's go over the structure of a nephron. So again, we have around 800,000 to 1 million nephrons. The number of nephrons decreases with age, and therefore, from our previous conversation, we can infer that the renal function will decrease with age. And then this is the structure of a nephron. So a nephron has, before we go into the structure, you note that nephrons there are different kinds of nephrons, but let's focus on this kind of nephron that is shown on the picture. You see that a nephron travels through the cortex and the medulla. So it's almost like having this pipe system that is crossing through different territories. Those territories will have, which is the interstitium, will have different concentrations of ions, different concentrations of water. So the pipe is experiencing all these different concentrations, which will allow movement of substances that matches, that tries to balance when it's diffusion with the interstitium. This may be too conceptual now, but let me just show you. This will be much clearer as we move along. Besides that note, let's look then at the structure of a nephron. So you have this big cup-like structure there that is altogether the renal corpuscle. The renal corpuscle has a capsule, that is the Bowman's capsule, and the glomerulus, which is a capillary system that we'll talk in a little bit. So this is the place where filtration takes place. Filtration, the word filtration has not changed its meaning since we spoke about it in the cardiovascular system. So filtration represents fluid coming out of capillaries. So the glomerulus is a capillary system. Fluid will exit into the Bowman's capsule. At this point, we can call this fluid filtrate. And now this filtrate, which is a very massive and coarse and unrefined process, is just really passing passing the plasma through a pore, through a bunch of pores. So everything that is small enough, in addition to other components, will pass. Now we need to adjust all that filtrate. And so all the goal of the tubules is to adjust how much we want back from what we filtrated and how much we can still send into the filtrated, that then will become urine. So, but to do these adjustments, we need a tube that crosses different areas of the kidney. Why? Because a great part of this adjustment will occur through diffusion. And remember, diffusion is from high to low. So if it all happened in one tube, in one little segment of tube, what would happen is that the filtration, we would filter, but then the diffusion, if we were to reabsorb something out of diffusion, in that little segment, the equilibrium would be reached. And that would be the end of it. We wouldn't be able to diffuse more. So we need to extend the length of those tubules so that more diffusion, for example, can occur. Again, I'm trying to give you just an overview, but this, by the end of this segment of lecture, will be clear. So we have a system where the filtration occurs, and then we have a renal tubule. So to understand how the filtration occurs and what the game of forces and pressures help with filtration, we need to spend some time thinking about the renal blood supply. So there are, in anatomy, you might have learned the renal arterial system in much greater detail. For here, what's important is basically what's on this slide. As much as then I'll have more slides with more detail. So the renal artery does exactly what the renal arteries do in any organ. So if you forget the naming of those segments, basically an artery becomes small arteries become arterioles, and arterioles become capillaries. So far this is not completely different from any other organ. But so this first arterial system is called afferent arteriole. So the renal artery becomes several renal arterioles eventually, and the renal arterioles become glomerular capillaries. But now, instead of these capillaries forming vanules and so on and so forth, and merging until they become renal vein, they will join to form another arteriole. That's called the afferent. And this afferent arteriole branches into peritubular capillaries. And these peritubular capillaries will eventually merge and eventually will form what will become the renal vein. So you have an arterial system that creates a microsystem there with an afferent and an afferent arteriole and a set of glomerular capillaries in between. And we'll see how this is very important to control the pressure inside of these glomerular capillaries. Let me show you different pictures to see this in different ways, and to try to see if one of those slides may work better than others. So this is the system. You don't need to know the names, but you can jump from renal artery to afferent arterioles, glomerulus, afferent arterioles, peritubular capillaries. And then in the peritubular capillaries will eventually the merging and vanules and so on and so forth become renal vein. Okay, so you see that the nephron in this picture is exposed as the glomerulus, where the filtration occurs, and it has the peritubular capillaries, which will be essential to keep exchanging with the interstitium. So let's look at this with more detail now, and let's look at the glomerulus first to fully understand what the glomerulus is and what is the relationship between the glomerulus and the afferent and efferent arteriole. So this is the image of a glomerulus. A glomerulus has an afferent and an efferent. So let this point be very clear. See, the diagram here really tries to show you that a glomerulus is this network of capillaries between an afferent and an efferent. So I hope you understand that you have here a point of entry and a point of exit, and then you have the glomerulus in between, and the glomerulus have pores, passages. So you have to play with it. You have to play a little bit with how do I get more pressure in the glomerulus. That will be the game we'll discuss in a little bit. But in addition to it, the picture also shows you the Bowman's capsule, that you can also call glomerular capsule. And that capsule is where the filtration, the filtration will project into. So whatever is filtrated will means that is a substance that moves from the capillaries, from the glomerulus, into the Bowman's capsule. So filtration is movement of substances, in this case, out of the capillaries, and in this case, into the Bowman's capsule. And so whatever is there is called the filtrate at this point. The picture also shows you more things as far as the layers of the capsule. Note that the capillaries will be surrounded by a visceral layer of the glomerular capsule, which is called the podocytes. The podocytes will be another layer added on the capillaries. So this would mean that if I'm a substance inside of the capillary, not only do I have to cross the endothelium, but I also have to cross the visceral layer of the glomerular capsule. And the picture also shows the juxtaglomerular complex, in which you see the macula densa, the mesangial cells, and the juxtaglomerular cells. This is much more better. This is just here so that when we talk about these concepts, the juxtaglomerular complex, you know what we are talking about. Okay? The picture also shows smooth muscle in the arterioles. Remember, arterioles have smooth muscle you can contract and dilate. So let's now put this, I've been telling you, indicating a couple of things that now I want them to be, now the time has come for them to become really clear. So we have a glomerulus system, so the capillaries of the glomerulus sitting between an afferent and an efferent. So how do things cross? How are things filtrated? So the first component is as the glomerulus, the glomerular capillaries are fenestrated, meaning that they will have pores. So now we are talking about something we can discuss. What can cross? What can be filtrated? And we can say that what can be filtrated needs to be small enough to pass the pores. Okay, so what are things that are too big? Cells will be too big. Most proteins would be too big. So only small particles can cross. But in addition to that component, there are other components that help control what moves, what the filtration is. We spoke a little about the mesangial cells. The mesangial cells, we are not going to talk much more about them, but they help regulating the blood flow within the glomerulus. And now, what is important to understand is that in addition to the pores between the endothelial cells of the glomerular capillaries, we have another layer, which are the podocytes. The podocytes will send food processes, and which represents that a substance needs to cross the pores between the endothelial cells, and then needs to cross the space between the podocytes, the process of the podocytes, which are called the filtration slits. And so you have here an image of the afferent and the afferent, just to remind you. And now we are going to go into the renal tubule. So the renal tubule has naming that matters. So the renal tubule can be divided into several portions. So you see the nephron has the renal corpuscle, and all the rest is a tubule. We can talk about a proximal portion and a distal portion. Oftentimes we add the word convoluted, so the proximal convoluted tubule and the distal convoluted tubule. In between, there's something called the nephron loop, or the Henle's loop. I have a slide with the spelling of Henle's. And the Henle's loop has an descending and an ascending limb. Each nephron is connected to the bigger system, the collecting system, through what we call connecting tubules. And then the connecting tubules are going to connect this then to the collecting system, which has collecting ducts. Which eventually drain the urine through a papillary duct that will drain to eventually to the renal pelvis. One way of looking looking at this is also introducing a little bit of physiology. So we have the very coarse and unrefined process that is filtration. Filtration is passing all the blood through a filter that has pores, and so only small things will pass, but also has other characteristics that we'll discuss in a little bit. But it's a very wasteful product. So if everything we filtered were to become urine, we would be dehydrated, for example. So now we need a system to call back the substances. And we have two systems. One that is unrefined, calling back as much as possible, and that happens in the proximal tubule, or proximal convoluted tubule. And then a system that becomes more refined and matches the needs of the body, which is a system that occurs more distally. So the proximal tubule does a coarse reabsorption, where the distal tubule is more selective, meeting the needs of the body, which means that it's in this segment that most hormones can act on. Remember, the kidney is very far from many other organs, but the hormones will signal to the kidney the need to handle certain substances differently according to the needs of the body. So we are going to go over this in more detail, but it will be very important for you to keep this idea. Filtration, glomerulus, a very coarse process of reabsorption in the proximal tubule, and then the distal tubule, along with other air, even the collecting ducts, will be doing processes of handling the substances in a more refined way, so that it matches the needs of the body. We have said everything that is important to understand this lecture, this first portion of the lecture. Now we are going to add details and better visualizations of the different concepts. So let's start with the capillaries associated with the nephrons. So here we have the afferent and the afferent arteriole. So afferent entries, afferent exits. So afferent enters, afferent exits. And you have the glomerular capillaries locked between these two. Remember that the afferent branch into glomerular capillaries. The afferent merges into what the fuck is this? So here we have the glomerular and the peritubular capillaries. The afferent branches into glomerular capillaries. The glomerular capillaries will merge to form an afferent arteriole, and their afferent arteriole branches in peritubular capillaries. So here this picture is much more important than it may seem, so pay attention to it. So the first component is the filtration, number one. So it's the passage of fluid, pay attention to the arrows, from the capillary into the Bowman's capsule. At this point we say that this is the filtrate, and then the rest of the nephron, the tubule, is going to communicate with the interstitium and indirectly with the peritubular capillaries. So the rest of the exchanges are through, basically, in a very simplified way, through the tubule and the peritubular capillaries. And whatever results from this process is going to be the urine. So the arterioles will help regulate the hydrostatic pressure, the same way we've talked before. So you open, an arteriole can be compared to a faucet. In this case would be the afferent. Afferent is the entry, is the faucet. The afferent can be compared to a valve, to an exit valve. So let's focus on the afferent. The afferent is compared to a faucet. So you open a faucet, you dilate the arteriole, you have more hydrostatic pressure. You close the faucet, you are going to constrict it's the same thing as constricting the afferent. You have less water pressure. So this water pressure, it's what's going to be very important to regulate what is filtrated. So let's come back to this in a bit. So the three processes that occur are filtration, where movement of substance in an unrefined way. You filter everything that passes. So the filtration is not selective for substances. So you don't filter potassium, you don't filter sodium specifically. You filter everything that passes the filtration membrane. Then all the other processes of secretion and reabsorption are selective. We can secrete more sodium ions, we can secrete more potassium ions, we can reabsorb more sodium ions, we can reabsorb more potassium ions. So secretion and reabsorption are selective to the substances, and secretion means we send back to the tubule. So we are secreting into the tubule. Reabsorption, we are calling back substance, we are reabsorbing, we are taking it back into the blood. So let's explore the glomerular filtration in more detail, and we'll finally go over a different view, but a more expanded view of the role of the afferent and the afferent arterioles. So the first component is to remember that filtration is a passive force that depends on the hydrostatic pressure and the colloidal osmotic pressure. Given the exam is cumulative, it would be a good idea for you to go over the filtration slides in the cardiovascular lecture and review them. So all those four forces apply to filtration, but the Bowman's capsule is basically a capsule that we can consider that does not have anything there to begin with. so there's no colloid osmotic pressure there. So all we have is the hydrostatic pressure between the glomerulus, which favors filtration, the hydrostatic pressure from the Bowman's capsule, which opposes filtration. We can consider the colloid osmotic pressure of the Bowman's capsule, which would attract fluid out. So it is a force that favors filtration. We can consider that 0. But the liquid, the fluid, the plasma has its own colloid osmotic pressure, and that opposes filtration. So pause here, go over this slowly, and relate this with the slides of cardiovascular physiology. So here, for us to understand, we consider the oncotic pressure of the capsule 0, and we consider that the main force that is driving the fluid out of the capillaries, so is driving filtration, is the hydrostatic pressure inside of the capillaries. When you go into pathophysiology, you may understand that if you increase the hydrostatic pressure in the inside of the capsule, you are opposing the filtration. This rarely occurs, but for example, imagine blocking something like a stone, blocking the renal pelvis. This increases the pressure in the tubules, which then increases the pressure in the glomerular capsule. So the capsules, so anything that clogs the tubules, let's put it this way, it doesn't even need to be a stone. I was just coming up with an example of a stone because it's a little bit more significant. Anything that clogs the tubules may increase the intracapsular, so the pressure inside of the capsule, the hydrostatic pressure. So I have this metaphor of a bucket full with holes. So the bucket full of holes could be a glomerulus. So the higher the hydrostatic pressure in that bucket, the more will come out of the glomerulus. But the question here is, what are those pores? Is that those pores actually are not a single pore or a single layered pore, but they have more layers. So let's talk about this, which is called the filtration apparatus. So imagine being a particle inside. So it is important that you orient yourself here correctly so that you know where we are. So on your left side, you're seeing inside of the vessel, inside of the glomerular capillaries. On your right side, you're seeing the capsule. So if I'm a substance that is inside of the capillary, I need to first cross. The first layer of protection, let's call it this way, would be the spaces between the endothelial cells, the fenestrations. Then I face another barrier that's called the basement membrane. Then I find another barrier that are the podocytes, and I can only pass through the space between the podocytes, which is called the filtration slits. So this is the movement, and it may help you to figure out this. So you see here there is an obvious problem as far as space, so a physical problem. So a substance needs to be small enough to cross those spaces. But the basement membrane poses another problem. The basement membrane is negatively charged. Remember, for that the rule of attraction in chemistry, so a positively charged substance attracts a negatively charged substance. So if the membrane is negatively charged, it will repel, it will block the passage of other negatively charged substances. The most important of those substances are the proteins. So the proteins have a tremendous difficulty passing through this. Why? Because they're big and 2 because they are negatively charged. What other substances or aspects of the cell of the blood have trouble passing? Cells, for example. If a cell, for whatever reason, can cross this particular red blood cell, it would be very damaged when it comes out of that membrane, out of the filtration apparatus, because he has to pass the space between the endothelial cells, he has to pass the basement membrane, and he has to pass the filtration slits. So it will come out very distorted, which will allow us to clinically to distinguish red blood cells that come out of the glomerulus or red blood cells that show up in the urine from anywhere else. So here a better visualization, and again it's the same principle, so you can use it to pause here and just to go over this in imagining what is a particle. Again, filtration is from the capillaries out into the Bowman's capsule or glomerular capsular. I also create this diagram just for you to understand. So you have the blue dots there represent small particles, and they will be able to cross through that space. But a red particle there is much bigger, and therefore will not be able to cross if the integrity of this filtration membrane or filtration apparatus is preserved. Okay, so pause here. It's very important to understand the filtration membrane. It's important when it comes to pathophysiology, to understand the different diseases that may affect the glomerulus. You can quantify this, and here it is the filtrability. So, meaning that how much of that substance how much of the substance in the blood can cross the filtration membrane. You see, water has no problem. So the one can be 100% there. The sodium has no problem. Glucose has no problem. This substance we'll talk about, inulin, has no problem. But when it comes to proteins, albumin, for example, has tremendous problem in crossing to the urine. Why? Because it's big, and 2, because it's negatively charged. Okay? So this is a very important aspect. Just it's written there on the slides on the left side how the filtrability depends on the size and on the charge. So to quantify this, how much filtration is taking place, so how much the glomeruli are working, we have what we call the glomerular filtration rate. And again, the glomerular filtration rate depends on these 3 forces, and the most important ones, the ones that vary the most, are the hydrostatic pressure inside of the capillaries. So I wanted to explain that very well here. So I'm going to use the bucket metaphor again. So the glomerular filtration rate is the volume of filtrate formed each minute. So one aspect that we are not going to speak a lot about, because it is better understood in pathophysiology, is that the size of the pores matter. So anything that can change the filtration membrane will affect the amount of volume that comes out of the capillary, the amount of volume that is filtered. You can see changes, for example, in hypertension and diabetes, many sorts of diseases. So if you increase the thickness of the membrane, for example, you make it harder for the fluid to come out. You are decreasing the filtration. But if you destroy, for example, the pores and make the pores larger, the filtration is more likely to occur. So this is, again, just a concept for us that you will better understand this when you go to pathophysiology. So I try to go back to this metaphor, without the whiteboard, I can't draw any diagram here. So imagining that the glomerular capillaries are a bucket with holes. And the holes are the size of the holes will affect the coefficient the filtration coefficient. So if the bucket has larger holes, more water will come out, more is filtrated. If there's smaller holes, less is filtrated. Of course, if the holes got smaller or got blocked anyhow, that would also impair filtration. But that's as much as we are going to speak about when it comes to the coefficient of filtration. Now, the most important pressures are the most important factors are the hydrostatic pressure inside of the capillaries. So, if we imagine that, remember again that the afferent arteriole is what's giving the pressure, what's letting pressure go inside of letting blood go inside of the glomerular capillaries. We understand that the more the afferent is open, the more fluid gets into the glomerular capillaries, and therefore the higher the pressure. But do not forget that the afferent arteriole is connected to the renal artery, and the renal artery is connected to the aorta. So a drop, for example, in blood pressure of the body, the systemic blood pressure, will also affect the kidneys. Okay? So either is the main pipe or the small tiny little pipes that are feeding the glomerular capillaries. The higher the pressure in those pipes, the higher the pressure in the glomerular capillaries. So anything that increases the arterial pressure, increases the afferent arterial pressure, will increase the glomerular filtration rate. So we can also play this in terms of vasodilation and vasoconstriction. So vasodilating, dilating the afferent arteriole, lets more fluid go into the glomerulus. Constricting it lets less fluid go. If now we put this in terms of resistance, we know that increasing resistance is vasoconstriction. So every time you increase the resistance of the afferent arteriole, so you vasoconstrict, you let less fluid go into the glomerulus, and therefore the filtration rate will lower. So I'm going to be using this metaphor, maybe too simple for, maybe it's not necessary for most of us, but maybe for some students this metaphor helps. So bear with me here. So if you imagine a bucket, and again the bucket is the glomerulus being filled up with water that comes from a faucet, the more you open the faucet, the more water pressure there will be in the bucket. So what is opening the faucet is vasodilation. So when you dilate the arteriole, the afferent arteriole, you let more water go, you have higher hydrostatic pressure in the glomerulus. If now you constrict, you close the faucet, or you're getting closer to closing the faucet, you have lower flow of water, lower hydrostatic pressure in the bucket, in our metaphor, in the glomerulus. Okay, let's not forget that resistance is the other way around. Dilating decreases the resistance, constricting increases the resistance. And the bottom line is that increasing the hydrostatic pressure increases the filtration. So the more water pressure we have inside of their bucket, the more will come out through those pores. What about the afferent? The afferent is the other way around, because the afferent is not feeding the capillaries, it's rather than allowing the blood to come out of the glomerular capillaries. So it's almost like an exit valve. So if we imagine a bucket now with a valve, an exit valve, the more you open that valve, the lower the pressure inside of the bucket will be. So by opening the valve, you allowing the pressure allowing it to decompress, allowing the water to exit and therefore the pressure will be reduced inside of the bucket. So when you, going back to the actual glomerulus, dilating the afferent, you allow blood flow to flow out of the glomerulus, and therefore the pressure inside of the glomerulus goes down. Closing or constricting the afferent, which is the same thing as increasing the resistance of the afferent, will do the other way around. It will block the blood from flowing out of the capillary, the glomerulus capillary, and therefore increases the pressure. And again, increased glomerular capillary hydrostatic pressure increases filtration. Well, I'm not sure if the bucket metaphor was the most useful. It took me a while, to be honest, to find all the images that I wanted. So I hope it is at least useful or helpful to some people. Going now into like more real diagrams that apply to the glomerulus, here it is the summary. So constricting the afferent, it's the same thing as increasing the resistance to the outflow of the glomerular capillaries. So that allows building up of pressure inside of the glomerulus. Increasing the resistance of the afferent is the same as reducing the hydrostatic pressure. That can also occur by decreasing the renal blood flow when we have a drop of blood pressure in the body. And here I will allow you to play with it and pause here and see if you understand this picture. So if you understand this picture, you are good to go as far as the filtration rate depending on the afferent and the afferent dilation and vasoconstriction. So we created a filtrate, and now we have two additional processes that we can do: reabsorption or secretion. Let's talk about reabsorption. The reabsorption includes the passage, so the tubular. So again, we oftentimes imagine from the tubule going directly to the peritubular capillaries, but let's not forget there's interstitium there. But for the sake of simplicity, we can just imagine that goes straight there, straight to the peritubular capillaries, and that's fine for the process. So how does the reabsorption occur? Through all the means of transport we spoke about. So it can be passive or active. It can be crossing the cell, which is transcellular, or it can be paracellular. Okay? And so the process oftentimes involves, so we're talking about tubule, interstitium, and interstitium peritubular capillaries. So we see here the amount of filtrate, the amount that is filtered for certain substances, and the amount that is going to be reabsorbed. You see, one general idea is that the more important they are to the body, the more they are going to be reabsorbed. So that's true for glucose, that's true for sodium. Sodium is very important for many reasons that we talked about, but for the sake of blood pressure, we need sodium to be reabsorbed so that water is reabsorbed. So sodium is an important aspect for osmolarity. So it will help keep the water molecules inside of the vessels. But you see, waste products such as urea are only reabsorbed up to 50%. Creatinine is a special molecule because not only is filtered, but then is also secreted, but is not reabsorbed. We'll discuss how that is important in a little bit. So we are not going to go over all the molecules because it's an intro to physiology course. I have to select material, but I would like to give an idea of some substances, how they are handled in the tubules. So sodium is a very important element, and the sodium ions are going to be mostly reabsorbed through active transport. Note that active transport is coupled with the transport of other substances. So there is co-transporting. An important co-transporting happens with glucose molecules. Glucose is a very important aspect for us to understand whether we should normally find glucose in the urine or not. So if our levels of glucose in the blood are within the normal range, we will filter glucose, but only a certain amount, and that needs to be reabsorbed. The reabsorption, however, occurs through active transport with sodium. So it's the sodium is actively transported, and the glucose goes with it. So it's a mechanism of co-transporting. But in any case, it involves a transporter. That's my point. And occurs then back from the proximal tubule cell back into the blood. It will go through a GLUT 1 and 2. But in both cases, whether it's being co-transported or using facilitated diffusion, in both cases use a transporter, which means that in both cases the transporters may be saturated. So up to a certain limit, we'll be able to reabsorb everything that was filtered, every glucose molecule that was filtered, and therefore we should not be finding glucose molecules in the urine. However, if our levels of glucose in the blood are very high, the amount of glucose that is filtered will saturate the transporters, and therefore we will not be able to reabsorb all the glucose that was filtered. Okay? So I hesitated a little bit in my explanation of the sodium glucose. I call it an active transport, but if we go back just to make sure you understood, I really can't be stopping the video too many times because it gives us too much work. But basically, you know that this is a co-transporter in which the glucose is passive, and the sodium is the one that is active. But this occurs through a co-transporter, a protein. So we talked only about these two. We can talk about many more, but let's leave it as is. Now let's talk about the secretion. So a lot of substances will be further secreted, whether that depends with the needs of the body or not. That normally is the action of hormones, but there's also secretion of anything that is wasteful. Anything that is wasteful should be further secreted, theoretically, and as a simplified version. But it's with the secretion of potassium and protons that will regulate the amount of potassium in the blood, so the concentration of potassium ions in the blood, and the pH of the blood. So let's just pay attention to one component here, is that not all the substances are handled the same way in the kidney. So again, just to recap, and so this could be a wonderful time for you to pause the video and try to recap it. So the amount that is excreted is the amount that it was filtered minus the amount that it was reabsorbed, plus if there was some amount that has been secreted. This picture relates with a table I showed you, but it helps you understand that glucose, sodium, urea are small molecules. They are relatively well filtered, but then in great part, more so for glucose and sodium, they should be reabsorbed. Other substances such as creatinine, not only we filter, but we also secrete a little amount. And then inulin and mannitol are substances that are not endogenous, meaning that we don't produce inulin and mannitol in the body, but if a patient is given inulin and mannitol, they should excrete the total amount that was filtered. And so we can use clinically, we use the blood urea nitrogen, BUN, and the serocreatinine concentration to estimate the glomerular filtration rate. Why? Because these two substances are filtered across the glomerular capillaries. We'll discuss that in more detail. Let's just, I want to just have a short note on the metabolism that happens by the tubules. So the tubules are important, the cells in the tubules are important metabolic components, not only for the metabolism of, for example, glucose, so they help with gluconeogenesis, but they also participate in the metabolism of amino acids. Remember, I'm not going to go over all these details about the amino acids metabolism, but note that when you talk about urea, we need to think that urea is derives essentially from the metabolism of amino acids. More specifically, again, I don't want to go over much detail, but you know that the ammonium ions are uptaken by the liver, for example, and that will allow the production of urea. But the kidney is also very important for metabolism of several drugs. So there's different enzymes in the cells of the tubules. And in different portions of the tubules, there are different cells, and those cells have different enzymes that are important to metabolize, in that sense, destroy drugs. So let's understand now a process of regulation of the channels and the transporters. For the kidney to do its function, the kidney needs to have access to signals that will reflect, that will be signaling the different components of the body, be it the blood pressure. So if the body has too much blood pressure, the idea is that you know that pressure depends on the volume, so the adaptive response to the body would be to filter more volume and therefore urinate more. So we get rid of more volume. The other way around, if we have a drop of blood pressure, the response of the kidney should be to conserve water. All those responses are more complex and they oftentimes are not this simple, but that would be the idea, the main idea. Likewise, if the body doesn't have enough calcium ions in the blood, the kidney should be saving calcium. If the body has too much potassium ions in the blood, the kidney should be excreting that potassium. But for that to occur, we need mediators, and oftentimes we're going to use hormones to be able to regulate all that adjustments that need to be done so that the kidney functions in a way that matches the needs of the body. And we are basically handling things in the way that we explained early on in lecture. So the idea is that the majority of the reabsorption occurs in the proximal tubule and loop of Henle. This is a very coarse and unrefined reabsorption. The distal tubules will then do the fine-tuning for most substances. So coming back to this picture. Okay? So this should help us understand several components. We will have the second portion of lecture in which we'll talk specifically about certain components that need to be adjusted. But I wanted to finish this portion by explaining a couple more of concepts. The first is the renal clearance. So the renal clearance has to do with how much of a certain substance that is in the blood we can clear out, we can send out in the urine. So for that, we need to know the concentration of that substance in the blood. We need to know the concentration of that substance in the urine, and then know the rate of urine formation. Don't worry about the equation. I'm not going to ask the equation, but that's how it works. Another aspect that we mentioned is the glomerular filtration rate. So we need to be able to quantify the filtration rate. And how do we quantify the filtration rate? So for that purpose, we are trying to see how well are the glomeruli working. So we are going to choose the clearance of a certain marker. And here where the problem can be more scientific or more clinical. So scientifically, we should find a substance that is only filtered. So a substance that's not secreted or reabsorbed. Because what we are trying to do is to assess the functioning of the glomerulus. And that substance is inulin. Inulin is not filtered, is only filtered, but is not reabsorbed nor secreted. So if we use that substance, we can actually have a very accurate estimate of the clearance for inulin and therefore the filtration rate, the glomerular filtration rate. However, the problem with that is that inulin is not produced by the body. So we would have to give the patient an IV with inulin to be able to measure the glomerular filtration rate. So we need to find another substance, and clinically the substance that we are going to use are essentially the urea, BUN, and the creatinine. What is the problem of using creatinine? The creatinine is freely reabsorbed, freely filtered. It's not reabsorbed, but is secreted. So we are overestimating. If we trust on the creatinine, we are basically assuming that the glomeruli are working a little bit more than they do. But clinically, it's still a good approximation. Okay, and so therefore it's more useful because it's easier to use, and therefore it's what we use. The creatinine comes from the muscle metabolism as well, so that means that we need to consider to a certain extent the muscle mass of an individual. It does not require an IV, and therefore is a reasonable estimate of the GFR, the glomerular filtration rate. So there are many formulas, you don't need to know them, but there are many formulas to calculate the creatinine clearance. And you see one here, and I brought you here for you to understand. It depends on the age, it depends on the biological sex, and depends on the mass, the body weight, the lean body weight, so the amount of muscle mass. Okay, and so we are done with these parameters, and we are now I would like to talk about micturition. So we finish everything. So we produce the urine drained into the ureter, and now is stored in the bladder. The bladder has stretch receptors that will allow to sense how filled up the bladder is, empty or completely full. Once the stretch receptors are stimulated, we are going to induce what we call a micturition reflex, a reflex that will force the urine out. That reflex is somewhat complex, so I have several slides, but I wanted to simplify, and you'll see that there are portions that are grayed out of the slide that are grayed out, so that you don't need to worry about them. But it involves basically all the autonomic nervous system, the parasympathetic and the sympathetic, and the somatic neurons. But again, for that, we need to kind of go over a little bit more of the anatomy. So if we focus just on the spinal cord, we can think about the spinal cord nerve that innervates the external urethral sphincter. We can think about the parasympathetic neurons that innervate the urinary bladder, and we can think about the sympathetic neurons that innervate the urinary bladder. But then again, you know that parasympathetic and sympathetic may be also influenced by substances, drugs, but also epinephrine, norepinephrine that are produced by the adrenal medulla. But note that the cortex also has an effect on the micturition. For example, people with seizures may, for example, suffer from incontinence during the attack. Likewise, for example, let me just give another example. Like, for example, some people cannot urinate very well when someone else is using the restroom. So that has nothing to do with the spinal cord, but is more likely to do with the brain and some psychological effect of knowing that we have people observing us. So let's just review the anatomy in the key points. So the urinary bladder has the muscle that's called the detrusor, and then it has an internal sphincter and an external sphincter. The detrusor is smooth muscle, so we already know that it depends on the autonomic nervous system. The internal sphincter is also smooth muscle, so closes and opens via the autonomic nervous system. But the external sphincter is actually a sphincter that has skeletal muscle, and that's the one that would allow voluntary control. So the idea would be something of this sort. So when we contract the bladder, the bladder is full. We contract the detrusor. We open the internal sphincter. All those steps are without our volition, so they're involuntary. And then if the moment is right, we should release the external sphincter. So here we have the detrusor, the internal sphincter, and the external sphincter. Again, the detrusor and the internal sphincter are smooth muscle, whereas the external sphincter is skeletal muscle. The female, the same thing. So we have an internal sphincter, the detrusor, and we have an external sphincter, which is voluntary control. The pattern of innervation is such that we have sympathetic and parasympathetic innervation of the bladder and the sphincter, the internal sphincter. And we have somatic innervation of the external sphincter, which is the pudendal nerve. I wanted to just show you that, again, it's important to understand for us that, yes, we depend on those direct connections, but the norepinephrine that exists in circulation, for example, will stimulate the receptors, the beta receptors, the beta adrenergic receptors that exist in the bladder, and so on and so forth, or the alpha receptors on the on the external sphincter. So don't worry about what kind of receptors, but just worry about, very simplified, that there is parasympathetic and sympathetic innervation. So and then again, the pudendal nerve affects the skeletal muscle like it affects any other motor neuron affects a skeletal muscle. So we have nicotinic receptors. So do not worry about understanding the complexity of this picture. I just brought you for you to remember that we are not only talking about direct connections, but if you have any drug that stimulates, for example, adrenergic receptors, you may have an effect on the micturition. Likewise, if you have a drug that has a cholinergic effect, you can act also on this. So the receptors are for us to consider. So let's put this in a more simplified version and summarized version. So here is the slide that I was telling you that I have two different kinds of text. One is written in regular font size, the other one is gray, and the gray is not extraordinarily important for us exam-wise, so it's just to add it because this issue is a little bit complex and it has a lot of subtlety, so I don't like to oversimplify it. So it's there for reference. But the idea is that as you're filling up the bladder, the sympathetic is the one that prevails, meaning that the sympathetic blocks emptying out of the urine, which ties with our idea of fight or flight. If you're fighting or running away, you don't have time to use a restroom. So meaning that, and all you have to do is thinking, okay, so how do I help using the sympathetic? How do I help this? You help by blocking the contraction of the detrusor, and you help by contracting the internal sphincter. Again, even the images may be a little bit complicated, and I took this from different sources, so they may not fully overlap. So do not worry about it. Just worry really about that little text there that is on your the top left portion of the slide. When a person is now in a different situation, so he's going to void the urine, we need the contraction of the detrusor and the relaxation of the internal sphincter. That's parasympathetic. So we are blocking the sympathetic, we are stimulating the parasympathetic. And then if the moment is right, we should be able to relax the external urethral sphincter, which occurs via the pudendal nerve, the inhibition of the pudendal nerve. So we have, as you fill up the bladder, you have relaxation of the detrusor and contraction of the internal sphincter. Both effects are sympathetic, although they take different receptors, use different receptors, and you contract the external sphincter. That's via the pudendal. As you empty the bladder, you contract the detrusor and relax the internal sphincter. Both effects are parasympathetic, and you need to relax the external sphincter. Okay, so bottom line, the sympathetic predominates as you fill up. You're filling the bladder. When we're emptying the bladder, it's the parasympathetic that predominates. Incontinence, just a little clinical note, incontinence can be seen as any problem of involuntary release of urine. That problem could be a problem of what you call a stress incontinence, which is basically when someone coughs, when someone laughs, when someone increases the abdominal pressure, there's leaking of urine. But there's another kind of incontinence that is urge incontinence. The urge incontinence, urge comes from the concept urgency. Urgency in urinary symptoms has to do with this very strong desire to use the restroom, to urinate, to void the urine. And so it's that's where the term comes, and that is normally associated with overly contracting the trusor. For example, an inflammatory process can irritate, can make the detrusor contract more than normal.